straight down to the neck. Look particularly on the left side because you're looking for a Virchow's node. Your Virchow's node is where your lymphatic system then drains into the left subclavian vein. If it's present, it can be a sign of GI lymphoma, so it's worth noting that one. Next, moving down onto the chest line. In a guy, you can always look at making sure that there's no sign of gynecomastia. Mix straight down onto the abdomen. Now, I've taken quite a slow progress for that, but when you do it in real time, it's an awful lot slicker. Next thing, you want to get down onto your knees. You want to make sure that the patient is comfortable, and for the purpose of the examination, you look in the patient's eyes so that you know if you're causing them any pain. You just pop your arms down by yourself there, mate. So first things first, we're going to do a superficial palpation check. Now when you're palpating the abdomen, you don't use little spiders across. You've got to keep your hand fixed and you flex like that. So you're remembering your quadrants on here. So we're going right iliac fossa, suprapubic, left iliac fossa, left loin or left lumbar, left hypochondrium, epigastrium, right hypochondrium, right lumbar, and then finally umbilicus. So it's a nice clear pattern from start all the way around to finish. So you're looking at the patient's face, hand on top. This is superficial. This is looking to make sure your patient's in no distress, and it will give you some idea if there's any organomegaly there. So you're just moving it down, moving it across, nice and swift, but still at this stage fairly gentle. If there's any guarding, rebound tenderness, you'll feel it. Next, we're doing deep palpation. This is the one where you specifically look at hepatomegaly, which is going to come down to the right iliac fossa, or splenomegaly, which is going to start at the left hypochondrium and it's going to work its way down. So we start here, and what I'm doing with my hand is I'm trying to scoop, imagine sort of like a dolphin going down. Get the patients, take a big breath in, as you scoop down, if there's anything there, it's going to hit the side of your finger. So big breath in, and out, and in, and out, and in, and out. So I can't feel anything there. Next, moving up towards the spleen, big breath in, and out, and in, and out, and in, and out. So far we've done inspection. This part I've just done there is palpation. We'll leave some other parts of the palpation to a second. Next I want to move straight on to percussion. Percussion is very simple. Actually, I've just forgotten something. Once you've done your deep, you've then got to block the kidneys. Now your kidneys are retroperitoneal, they lie at the back. So with an examining hand on the front, you take your hand, you push it round the back, and you bring the kidney up to the examining hand. So you're kind of there, pushing it forwards. So again, looking at the face, lift it up, and lift it up. Next you're moving on to percussion. It's worth percussioning out the spleen. Remember that the spleen naturally will live at the internipple line. Pop your fingers perpendicular to that, and it's tap, 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 tap. You can do the same on the other side of the spleen as well. Now, I'm then going to check clinically for ascites. Ascites is just fluid within the abdominal cavity. This time, you place your finger longitudinally, and what we're looking for, and this is a bit you've got to be absolutely flat. I'm just going to put you flat there, right? Yeah, make life flat. So, hand in the centre. If you think about it, you're going to have an air fluid interface at some point in here. If it's really bulging up, it's obviously going to be much higher. It can be quite subtle, and it's going to be level with, as a meniscus. It's always going to be horizontal. So you start here, and you move towards you. So let's say this is resonant, 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 dull. I'm being descriptive. Go above it again, resonant. Go below, dull. So you found exactly where it's changed from it being air into fluid. This is the shifting dullness. Next, ask your patient to roll over on the left side. If you just roll over there from the roll. There you go. Keep your finger exactly where it is. If you just rub the belly a second, allow gravity to take its course and the fluid will drop. Now when I tap back on this, this should now be resonant. And it's resonant. So what you've done is you've shifted the dullness. You've clinically proven that there's an ascites inside the abdomen in there. Roll yourself back onto this one here. Next is a couple more tests. I'm just going to do something called a liver scratch. Liver scratch test is kind of one of these tests for academic value really more than anything else. What you do is you place your stethoscope over the liver, and then with every decreasing circles you literally scratch the abdominal line, and as soon as it hits the solid of the liver, no laughing, as soon as it hits the solid of the liver you'll hear it. The good test to do this at home so you understand what it feels like is to put it over the edge of the rib and start around the abdomen, and then as soon as you hit the rib you'll hear it. So that's the definition of a liver scratch test. And as you're coming up to the completion of the examination, one of the things I forgot to mention on inspection was looking for a caput medusa, and that's literally where you've got venous vessels coming up to the surface and then spreading out like the head of a medusa. Always asked to inspect the hernial orifices, always asked to do a rectal examination, and then you've finished. And all that remains then is for you to thank the patient. You turn to the examiner and you present your findings, whether or not they are negative findings or whether they are positive findings. So what you would say is, Rob is comfortable and relaxed at rest, he's able to lie flat without causing any respiratory embarrassment at all there. I could find no features of chordoonychia, of leukonychia, of pulmonarythema, of spider nevi. There was no features of icterus, the mouth looked clean and healthy. I could not detect a Virchow's node. There was no features of gynecomastia. The abdomen was soft to palpate, there was no sign of guarding or rebound tenderness, there was no organomegaly, and I could not detect shifting dullness. One more test I've forgotten as well is something called a fluid thrill. When you're dealing with ascites, you can get the examiner to place the hand on the abdomen. So if I just borrow you for a second, if you place your hand like that, it's going to be difficult to remember. So if you're unsure, again, little value, you can hold the abdomen on one side, with your finger, flick the abdomen. If there's any fluid, you're going to get the thrill that goes all the way through. Just remember that on the last minute. You see, you've asked to inspect the hernial orifices and perform a PR, and that's the end of the examination.